Good morning, everyone. My name is Suzanne Tierney. I'm the CEO of the Lupus Foundation of America's Greater Cleveland chapter. And I'm really excited this morning to invite you all to this wonderful chat we're going to have. It's our What's Up Docs Q&A, a town hall meeting with MetroHealth's finest. And I'm very excited to see all the wonderful speakers we have today. Some housekeeping rules for those of you that are here in person. Please silent your cell phones. If you need to use facilities, outside the door to your left is some facilities. We will be breaking later on, and the questions that you have today, please keep them, for those of you in the audience, not so personal, okay, more generic, all right? And as a disclaimer, your doctor is the best one to give you medical advice. Today's information is an educational information, and this has been long in coming, and I know many of my fellow Lupians have a lot of questions at the end of our educational programs. So we kind of ditched the educational programs and moved right to questions and answers. I'd like to thank our sponsors today, of course, starting with the Ohio Department of Health, the Ohio Commission of Minority Health, Aurinia Pharmaceuticals. We're very, very grateful for all the support that they offer us for our educational programs. Feel free to get up and stretch for those of you that need to do so. For those, the audience, we have a very large virtual audience today. Can't seem to get a lot of you to come out in person anymore, but I'd love to see you at the next one coming out. I could use a hug, you could use a hug. So moving forward, let you introduce the legend of our medical board, who has been more supportive. We are more blessed than we deserve at the foundation. So I'm going to pass the baton to Dr. Stanley Ballou.
Thank you very much, Suzanne. I really like the legend part, actually. But I'd like to welcome all of you here, all of you who are sitting here, and those of you who are joining us virtually. I think this is going to be an exciting and fun event, different than we usually have, not just a lecture, but an opportunity to get questions answered about a very complex illness, lupus, that many of you know about, but that we all struggle with finding answers to provide the best treatment for individuals who suffer with this disease. I'm joined here by 5 colleagues who are all experts in lupus with various interests, and I'll let them introduce themselves. With respect to my own background, I'm a graduate of the University of Pittsburgh Medical School and did my training here and at Case Western Reserve University, and have been privileged to work with the Lupus Foundation for at least 20 years. It's a wonderful group. They're very focused on helping individuals with lupus and improving outcomes for people who have this illness. So that having said, I'm going to pass this baton over to our group, who is going to introduce themselves, and then we'll get started with answering all of your questions. Thank you.
Hello, I'm Marie Antonelli. I am Dr. Ballou's protege. I have been at Metro for the last 15 years. I trained here after University of Toledo Medical College, trained under Dr. Ballou, and I was lucky enough to join him. And now I get to train some of my colleagues like Dr. Basharat.
Hello, everyone. My name is Bisma Basharat. I did my medical training at Sabre University, and I just finished my internal medicine training in Michigan. I'm currently being trained by my wonderful program directors here in rheumatology for fellowship, and I'm excited to answer your questions, and hopefully we can all take something away with us today.
Hello, I'm Dave Crow. I am the chair of the Department of Dermatology. I have been at Metro for almost 14 years now. I trained at the University of Cincinnati. I did my residency there as well. And I'm very interested in lupus and autoimmune disease of the skin. And I also am very interested in teaching. And one of the people that I teach is right next to me. This is Dr. Abidi.
Hello, everybody. Nice to see everyone in the crowd. I'm Dr. Hussein Abidi. I'm actually from Texas. Originally, I did my training at Texas Tech University a year of internal medicine in Florida. And then I'm lucky enough to be in Cleveland now to do my residency in dermatology. Very humbled to be trusted to educate everyone and talk to you about your questions.
My name is Dr. Chris Zavitas. I'm originally from Michigan. I did my training, my medical school at Wayne State University, residency at Trinity Health in Ann Arbor, and did my fellowship here at Metro as well as University Hospital in nephrology. And I'm now an attending physician of nephrology here at MetroHealth, and looking forward to answering any questions, particularly about lupus nephritis or any kidney issues related to lupus.
Thank you very much. So we will now get started. I have a list of questions, which I'm going to just briefly read, and any of our experts here will be able to address the question specifically related to whether it's related to kidneys or skin problems or any other aspects of lupus. And I can start with the first question. Do you have suggestions to help with significant fatigue in a 20-year-old college student, which is not an unusual time for an individual to develop lupus, with low platelets and low levels of ferritin, which is an iron-binding protein? The patient takes a multivitamin, a medicine called Plaquenil, which many of you have heard of, and 100 milligrams of Imuran. They are no longer on prednisone. And I'll let one of my rheumatology colleagues address this question.
So this question, does the patient have a diagnosis of lupus? This can be seen, yeah. So I mean, in lupus in general, as we know, fatigue is a very huge component of what is felt. It's a very kind of prominent symptom. It's something that can be experienced in many different ways, and it's a component of the disease itself, and at times it can be a side effect from different kinds of medications that patients can be on from lupus as well. In a patient with worsening fatigue and a diagnosis of lupus and currently having medications that are prescribed for lupus, my advice really would be to have your doctor kind of assess currently what type of symptoms you're going through and potentially have some further labs done for, evaluating. Definitely low platelet counts, low blood levels can worsen your anemia and can also worsen your degree of fatigue. And they may have suggestions for seeing if there are any changes to the current regimen for lupus that may be done. The other very important thing is in lupus, there are many other causes of fatigue as well. And so your doctor may be able to kind of search through other symptoms, other lab work to see if there's something else that is happening at the same time that might be worsening your fatigue, such as an infection or other causes.
I would say, though, common things are common. College students are often very fatigued. So keeping general wellness kind of at the focus. So having like regular sleep schedule, what we call sleep hygiene. So going to bed at the same time, making sure you're waking up at the same time, even on the weekends, things like that. Ideally, we don't like to take naps, even though naps are great. We don't take naps so that you're sleeping during the night. Making sure exercise is part of your wellness routine, making sure we're both mentally tired as well as physically tired at the end of the day. And then also other things outside of lupus can contribute, things like thyroid disease, which often we know that autoimmune conditions cluster. And so comorbid or also having thyroid problems with lupus is common. So making sure the thyroid is adequate, as well as the low ferritin can be suggestive that there's an anemia, which can make people feel sluggish and tired. I don't think it said if this was a female college student. So menstruating women will lose blood every month. And so it's not uncommon to see an anemia that comes and goes and can contribute to fatigue.
Excellent. Thank you very much. That's a complex issue, fatigue. I might just say that almost all patients with lupus eventually experience fatigue at some point, and the guidelines that they have just given you are useful for all of us to remember and to discuss with patients and relatives. The next question is a question for dermatology. How do you recognize lupus in deeply melanated skin that may present atypically than in less melanated patients?
So I'm happy to talk about that. So it's interesting because in deeply melanated skin, in many conditions, it's more difficult to diagnose a lot of skin conditions. But for some of the most common types of cutaneous lupus, like discoid lupus, it's actually a bit easier. And the reason it's easier is because the condition causes scarring of the skin, and that scarring causes reduction in pigmentation to the point where the contrast between the melanated skin and the scarred skin is quite pronounced. And that's less easy to see in patients with lighter skin because that difference between their natural skin tone and the diseased, the scarred skin is not as prominent. So I often have a harder time diagnosing discoid lupus in people with lighter skin than in darker skin. That contrast is not as prominent for some of the other types of skin lupus. For instance, acute lupus of the face, there's less of a contrast between areas where the condition is versus not. So it is a bit more difficult, and the erythema, the redness from the conditions, is masked a bit by the skin tone, and that's the problem that I have in a lot of other skin conditions, is the redness is not as obvious.
If I could bounce a question to Dr. Abadi and Dr. Crow, do you make any recommendations for darker skin tones as far as lupus skin protection, as far as SPF application, sun avoidance, et cetera?
It's a great question. And I was reading about this the other day in terms of a patient asked me about getting their car windows tinted. And the reason for that is that sometimes the car windows usually block ultraviolet B light, which is the type that burns your skin, but they don't really block ultraviolet A very well. And ultraviolet B is usually what causes worsening of lupus skin conditions. So, but sometimes people with lupus are sensitive to all types of light, including even visible light, the light around us. So in those folks, it is reasonable to get your car windows tinted with ultraviolet A blockers. Now, unfortunately, most traditional sunscreens are very good at blocking ultraviolet B. If you're looking for ultraviolet A protection as well, you generally want to go with the physical sunscreens, the ones that contain zinc or titanium as a base ingredient, rather than the ones that contain the chemicals that are often, blamed for destroying coral reefs and things like that. And a lot of that is true. So I generally recommend physical sunscreens for everybody anyway, just because I want to avoid that whole scene for a few years until we get more information about it. But those are some kind of practical tips.
And then, so applying sunscreen is one thing, but also identifying when you can be exposed to UV radiation is another. It's not just going to be on sunny days. Even a day kind of like how today was outside, the sun can still come through the clouds, and the UV radiation, the light might not be there, but the UV radiation can still come through. So it's going to be really a daily thing that you have to almost like religiously perform. There's other things you can also do. I think some sports brands also sell clothing where it's not a SPF rating as you would see in like a lotion, like a sunscreen lotion, but a UPF rating. And I think sometimes even when it's not like branded for sun protection, they sometimes have UPF ratings on their clothing, and those type of barriers can be very helpful too. And then also reviewing the appropriate way to apply sunscreen. A lot of people think one and done is good enough for the whole day, but really after like 2 hours, it starts to wear off. And if you're getting wet or sweating, then it can also wear off. And so it's a task, but it's a lot of remembering to kind of how to use it properly to best improve your chances of not getting a flare from UV radiation.
Thank you kindly. So we do have another dermatology question here. Are there any steps you take if the skin presentation does not fit the standard diagnosis with the butterfly rash?
Well, the main thing that you can do, which is probably most important, is seeing a dermatologist who's trained in autoimmune skin disease. And most board certified dermatologists are well trained in that as part of their training. That being said, there are those of us that are less skilled than others. And sometimes you may see a dermatologist who does not know how to diagnose lupus in the skin or has not seen enough patients to be good at it. So in those situations, a biopsy of the skin may be indicated to direct management, and that is often what we do. Other things that we can do is we do a full skin exam, because sometimes findings elsewhere on the skin can be helpful in making the diagnosis. So those are the two things I would say that are most important. See a trained dermatologist who's experienced with skin, and also have a full skin exam and perhaps undergo biopsy.
Thank you very much. So the next question is a bit more general, but I think I'm going to direct this to our nephrologist. What advice do you have for patients to ensure they get an adequate assessment for the diagnosis if they do not have typical lab work? And I think that this is important for our kidney doctor to answer, because all of us are very concerned about making the diagnosis of kidney disease if the lab work doesn't help us very much.
Yeah. So lupus, one of the places it can manifest is in the kidney. And, kidney pain, everyone will think, sometimes people, oh, my back hurts, is in my kidneys. The scary thing about kidney disease is, you don't tend to feel it. It's how we assess it best is, visually, what can you see? Are you having foamy urine, which can be signs of protein, which isn't supposed to be in the urine? Is it dark? Is it bloody? But as well, what's important as part of the lab testing in patients with lupus is doing urine analysis, looking to see if there's things that aren't supposed to be there, like blood and protein. Particularly, just because you're not having manifestations in other organ systems, you may still be having lupus manifestation in the kidney. And it is very common for patients with lupus to have some kidney disease as well. It can be up to 50%, and lots of risk factors, including genetics and race and age at onset and relapses and all those things. So, it's certainly important as part of any routine analysis to have urine looked at as well, to see if these manifestations are starting to affect the kidney as well.
Thank you very much. So the next question is for our rheumatologist. How do you ensure providing an unbiased second opinion when you have access to patient records from the previous doctor?
Very good question. I think that seeking a second opinion in any sort of, in lupus, in any sort of situation where someone is experiencing so many different, varieties of symptoms in their condition, may feel that the medications, the treatments that they've been started on are not necessarily assisting them. So seeking an opinion from a second type of way, first of all, it seems like an okay thing to do. I understand why one might want to. And I think the way that as doctors, we would be able to kind of further assess and see whether or not that second opinion and our assessments for figuring out what the patient is feeling is really through our labs, and really having a great conversation with you as a patient and figuring out what type of symptoms are affecting you in all types of fronts, and seeing what the previous regimens, the previous medications were doing, how they were assisting, and kind of further figuring out what didn't work so well in the past. And I think like that kind of would be the best way. We have seen many times like second referrals, and I think that it's a very understandable thing. As a patient, you're seeking something for yourself, you're trying to protect your own health and do something for yourself. So going for that is a good option for yourself. Yeah.
Yeah, I think it's a excellent question for a challenging situation that we find many of our patients in. Currently, we are at an awesome place in history where we get patients who come and I can just open the chart and see when they were at the university hospital, they were at the Cleveland Clinic. But you're right. I open the chart and I see, ooh, this person saw so-and-so, and I may have a bias, plus or minus, right? I think we're also at a time where medicine crunches time, and so we don't have hours with a patient like I wish I could. I try to not bias myself by looking at those notes. I look only at the labs. I listen to the patient. And then I also try to explain to the patient that sometimes differences of opinion are okay, but you're in the right place, that you need to find the right doctor for the right time in your journey. But it's a tricky situation.
Okay, thank you very much. And I agree that's a challenge that we all face, but I think that we're doing it appropriately as our colleagues suggested. So next we have a couple of questions that I'm going to group together. They have to do with our bones and osteoporosis, which has become an important issue for people increasingly in the past few years. And we recognize this as a problem in lupus. So I'll just mention a couple of questions and let my rheumatologic colleagues address this. What can we realistically do to rebuild the bones between diet and exercise? And what can we do to keep the healthy bone we have? And can osteoporosis affect your skull or your jawbone? So those are three questions. How do we keep our bone? How do we build our bone? And where can we get osteoporosis? In which bones?
Okay. So very good questions. Bone health is a very important thing. I guess to kind of loop in the last question into everything. So osteopenia and osteoporosis, yes, they can affect the skull and the jaw bones. They can affect any bone, really. And they involve a sort of progressive decrease in what we call bone density. The structure and the thickness of our bone can decrease over time in something like osteoporosis or in osteopenia. And that's something that we can track with different x-rays and imaging through a doctor. So that's something that we have good screening tests for and assessments. In terms of building bone through diet and exercise, we often suggest having a diet that's fairly well-rounded in vegetables, in fruits, as well as lean proteins, as well as whole grains, but also in a good amount of calcium intake, whether that be from yogurt or cheese or milk, to help make sure that you have a good amount of these types of calcium entering your diet through food rather than supplementation first. So the most important way to do it is through your diet. And then second, when we do your lab work further, we are always checking for levels of calcium and vitamin D. And so if you're falling short on these things despite a diet, we may recommend further treatments with an additional vitamin D or calcium supplement, depending upon where you're sitting at with these results, depending upon your bone density from our assessments of whether or not one might be diagnosed with osteoporosis. And then one final thing I would like to add in terms of exercise. Exercise is a very kind of important thing that one can partake in, especially with lupus, to help manage their overall symptoms, but also strengthen their bones and improve their stress. Usually the type of exercise we recommend is a low impact exercise. So a type of exercise that doesn't necessarily strain or didn't necessarily cause a lot of impact on the joints, and really helps instead with kind of improving the muscles that surround our joints to help build our overall strength and also prevent stiffness and improve our flexibility. So the type of exercises that can overall help your bones and help your overall strength would be walking, for example, like low impact walking. Some people love swimming, and I've heard other people really do enjoy cycling, but that would be all, for example, instead of high intensity running or incredible weightlifting. I've also heard people find a lot of benefit from exercises such as yoga, as long as you're not overstretching yourself too much. And some people also enjoy like a low to moderate intensity Pilates, but there are a lot of options out there that are kind of low impact and help prevent further strain on your joints, but also improve strength in other ways.
All great points. I would just add a couple of other things. Bone health is extremely important, in particular to lupus patients when a person is on steroids. So even very low doses of steroids are toxic to bones. And so that's something to think about and discuss with the rheumatologist about whether or not a person should be screened for osteoporosis at an earlier age. There's a whole set of guidelines about treating bone loss if a person is on long-term steroids. There are other things that are commonly toxic to bones that are generally very popular in the environment. So smoking, very toxic to bones, alcohol, and then also for younger women, birth control. So in general, we think of combined estrogen and progesterone birth controls are sort of neutral, but Depo-Medrol, Depo-Provera, sorry, that's the Depo shot, which is very commonly used in young women, is quite toxic to bones. And I've seen a lot of young women on this for many, many years. And basically that's just more and more bone loss that theoretically should rebound when a person stops it.
Excellent advice from Dr. Antonelli, who is our bone expert here at Metro in terms of treating patients with osteoporosis and osteopenia. One other question about this, which is a bit of a challenge. Should a patient with borderline osteoporosis and a severe reaction to reclast and no change in the bone density, retry reclast for a second time?
So reclast, zoledronic acid, is an IV, an infusion version of a bisphosphonate, which is a very commonly used osteoporosis medication. There's a common side effect of having sort of flu-like symptoms after the infusion. The thought is that that medicine is going deep into the bones and there's sort of reaction at the bone level. It can be mild, just muscle aches or fatigue, and it only lasts a few days. However, there's a very, very small subset of patients that has quite severe reaction. And from what I understand in the literature, a person who experiences this on the first infusion should have subsequently less severe infusion reactions. However, I think it's kind of understandable that a person be a little bit reluctant if it is a very severe reaction. As far as the comment on response, no change in bone density response, the trials for reclast or zoledronic acid are generally for 3 to 6 years. So not having a response after 1 year doesn't necessarily mean that it didn't work. The studies are that you should have it for several years. And I've personally seen that if we repeat that bone density too early, we don't see a response. We might see a change in blood tests that show that it's actually working, but then we get a rebound, and within several years after, the bone density seems to bounce back. So that's always a tricky situation. We do have other options, and I mean, I don't know what I would personally do, whether or not that would be the right thing to go back to. I love oral bisphosphonates. They're cheap, they're well studied, but they can cause a lot of GI issues. And as somebody who suffers from a lot of heartburn, I said I'm not necessarily sure I'd be up for it myself. So.
Okay, good answer. So now we're going to move into a different area. What's the best way to combat hair loss? And I presume that's going to be for our dermatologists.
So when it comes to hair loss, it's multifactorial. So in lupus, patients can usually experience kind of this breakage of their hair, and you can have hair coming out. And the number one thing before even addressing the hair loss is addressing the disease process. Often in dermatology, we see different conditions that can lead to hair loss. A lot of them we can blame on underlying inflammation. And in this case, it's a little similar. So it's really important to work with the dermatologist, work with the rheumatologist, work with the whole care team to get that inflammation under control. So that way you can give your hair the chance to grow back. If in the case of a condition like discoid lupus or like chronic lupus, I think Dr. Crow mentioned it earlier, where you have scarring of the skin. That is a more tricky scenario when you have scarring of the skin, it can also make it, I would say, I'll say very, very difficult to get hair growth back in those areas. Really, when it comes to hair medicine and dermatology, the scene is not the best at the moment. We'll see what comes in the future, but really the goal is to prevent further hair loss. When you have a scarring alopecia, is what we call like scarring hair loss, we try to prevent further, and then really the strategies to kind of get hair back are not that great. Sometimes we can offer things like minoxidil. You can do like I think it's referred to as Rogaine, but there's topical forms. We do like a foam or solution or even oral. But the tricky part with that is if the area is scarred, you may not experience any hair growth, but maybe around the lesion where there was inflammation, you could have some back. And often if you stop minoxidil, it'll often lead to your hair then that you gained from the minoxidil kind of going away again. So it's a little tricky situation when it comes to those scarring hair losses.
I can briefly mention what can be done with those areas where the scarring occurs, which is they're not all that practical, and they're not the greatest treatments in the world. But I would say the most effective treatment for treatment of scarring hair loss, if there's truly not hair coming back, is hair transplant. The problem with hair transplant is you can only do it when the lupus itself is completely calm, the discoid lupus, to the point where there's no redness, no inflammation, the condition is adequately treated, which again is the best treatment for hair loss in lupus is active systemic treatment or active local treatment. That being said, if your lupus is well controlled and you have a patch of scarring hair loss, the best way to get adequate coverage is to have hair transplanted from the back of your head to the areas of hair loss. The problem is this treatment is very expensive. You will occasionally, if you have a very good physician and letters are written, you can occasionally get this covered by insurance. But if it's not covered by insurance, it can be quite expensive. The one saving grace is that the areas involved with lupus hair loss can be very small, so that would reduce the cost of the grafting of the hair. Traditionally, like for instance, if I got a hair transplant, which I could probably use, it would cost probably $10,000 to $15,000. If you had a smaller area, which if you transplanted hair into a smaller area, it's probably more like a few $1,000s. And if you got it covered by insurance, potentially less. So it's not as if there's no hope for scarring hair loss. It just makes it very difficult to treat.
Comment on biotin for hair loss?
Sure. There's very limited evidence for biotin being helpful for hair loss, and I know that's going to be a statement that is going to be. I think a lot of people in this room and potentially online are on biotin, and that's fine. But unfortunately, it does interfere with some of our lab values, in particular thyroid function, things like that. The only thing that biotin has been proven to do is help a bit with nail fragility. But in general, I don't recommend people take it, and I don't think there's enough evidence to recommend people take it on a regular basis. I would say the most useful thing that people can do to help with hair loss in general is to also make sure that they're not deficient on other lab work. For instance, iron was mentioned earlier, the ferritin level. If that's low, which can happen a lot in young women in particular, that can impair our ability to grow hair. And I see it all the time within and outside of the people with lupus, where this is a problem, and it's often underdiagnosed and missed for many years.
Thank you. This is useful advice. So now we're going to turn to a different area, and we're going to address this to our kidney doctor. What can you tell us about the new drug Equicel for the treatment of lupus nephritis, which is something I'm not familiar with? And as a corollary to this, I'm going to, since there has been new treatment for lupus nephritis or lupus kidney disease in recent years, I'm going to have our nephrologist address this question.
So it's actually a relatively newer medication that was just approved by the FDA to start human trials looking into its efficacy or whether or not it has an impact in lupus nephritis. It's a T-cell therapy. It's been used before in other conditions, neurologic mainly, like myasthenia gravis and MS, multiple sclerosis. So essentially, it's something that's just kind of starting to be looked into in human trials. So not something that is going to be mainstream for a while, if depending on what the trials show. So yeah, and I think it was approved just a few weeks ago by the FDA, so very early on.
But Chris, we do have other newer treatment options, don't we, for lupus kidney disease?
Correct, yeah. And some of these other therapies too, it's dependent on, so just to kind of speak a little bit about like lupus and how it affects the kidney is how it affects, actually this kind of moves, what I'm about to say kind of moves into one of our next questions talking about stages of lupus. So I'll go a little bit into that. So from a kidney's perspective, whenever we see, like I was mentioning earlier, protein and blood and things in the urine, we often will talk, depending on how much protein, how well the kidney's cleaning the blood, we'll talk about doing a kidney biopsy. And that is essentially to help guide us into what different therapies, and it's all dependent on the stages of different classes of lupus that we see. So when the way lupus will affect the kidneys is you get these complexes of antibodies and antigens, and they deposit sometimes in different parts of the filter. And where they deposit kind of affects not only what people notice, like, oh, I have a lot of protein in my urine, I'm getting swelling, or I have blood, I have high blood pressure that's new, and all those things. So figuring out where those deposits are, what parts of the immune system are being activated will guide what kind of, tell us what different classes, things, what we diagnose on the biopsy, as well as what the therapies are. So they're actually our global organization, the KDIGO, has recently changed has some new updates on the guidelines as to different therapies for lupus, and a lot of it is individualized depending on relapsing therapy, or like are people having multiple relapses of lupus, especially like not only in the kidney but in other organ systems. Are they having more protein? Is there the cleaning ability of the kidney, has it been significantly impaired? So there are different regimens that we do depending on not only what we see on the biopsy, but as well as other factors. So those therapies, those guidelines are new as of 2024.
Are there things that all lupus patients should do to protect their kidneys, medications to avoid blood pressure control?
Yeah, so blood pressure control is an important thing. We recommend patients are on medications called like RAS inhibitors, so lisinopril, losartan, things that are in those groups. Hydroxychloroquine, is recommended as well from a lupus nephritis standpoint, because it, people who are on that long term, have less recurrences of lupus flares, longer duration before progression to advanced stages of kidney disease. Medications which are now recommended too for people with protein in the urine with lupus nephritis, high amounts, is SGL2 inhibitors, so like Jardiance, Farxiga, although trials looking into specifically patients with lupus are just not there yet. It's more what we've noticed in people with diabetes and non-diabetic kidney disease. So the efficacy in lupus itself, the recommendations are to use those kinds of medicines too, but there's not too much data yet looking in lupus patients specifically. Dietary things, it depends. For most patients, we recommend, particularly those with high blood pressure, less than 2 grams of salt in the diet. And people with more advanced kidney disease, we look at to phosphorus restriction. There's a lot of relation between as the kidney function decreases, the kidney can't get rid of phosphorus. That can build up and essentially can increase, like calcium and phosphorus will complex together and can cause, they can deposit in different vessels, and so they can increase risk of cardiovascular disease. So those are going a little bit back into the bone health and things too. That's dietary, something we recommend for people with later stage kidney disease with that their phosphorus is high, is restricting their phosphorus as well. There have been studies too looking at like animal proteins and like heavy, like eating red meat and things, and will those how does that affect progression of kidney disease? And it's a bit hit or miss in like the earlier stages of kidney disease, how effective reducing protein is. And one of the concerns too is as kidney disease gets more advanced, people don't feel good, they lose weight. If you're restricting your protein too much, you risk for being malnourished. And so whether or not protein restriction is recommended early on is kind of hit or miss, but certainly later on with late advanced kidney disease, I don't tend to restrict protein much because the risk of, especially if somebody is saying I'm not eating well, I'm not feeling well, I'm losing weight, because the risk of bad things from low protein is high. So those are some of the things we recommend for everyone.
Thank you. Some more good advice. We'll move on to another question, which addresses an important issue I think many lupus patients face. If lupus is well controlled, which we always hope for, is there any benefit to remaining on a weekly dose of methotrexate at 10 milligram? And I presume this would apply also to remaining on other medications that you might take, such as Plaquenil or Imuran or other medications if you're doing well. I'm concerned about the possible effects of long-term usage. Critical question for one of our rheumatologists.
That's a really good question. So medications like methotrexate are medications within lupus that help to, in many ways, calm down our immune response from the lupus, and are medications that are taken over a long period of time, and wanting to kind of further assess if you're doing well and you're not having any flares, you're not having too many symptoms, and your labs look okay. Is it okay to come down on this medication? Do you need to be on this medication for a long time? The important component of this is that methotrexate could be assisting with controlling you outside of a flare and keeping you in a sort of preventative state. And so having a further discussion with your physician regarding whether or not that should be continued really should keep that in mind, because perhaps coming down on any dosage or reducing it may cause further recurrences. Keeping in mind side effects for methotrexate is also something that's very important. Methotrexate can cause damage to our liver, and for that reason, we do have a lot of regular lab work that's done to help monitor for any form of side effects. So that's something that with your doctor, having a good relationship with your care team so that you have regular labs drawn and a good conversation so that we can on a continuous basis assess for both the labs as well as for whether medications should be continued.
I'm going to counter and actually ask Dr. Ballou. I'm not aware of any studies outside of hydroxychloroquine or Plaquenil for long-term benefits in lupus for lifelong reduction in progression, damage, accrual. We know for sure that lupus patients who are on hydroxychloroquine, Plaquenil long-term have less flares, less morbidity, less mortality. They die less from lupus. But a person who's on, say, methotrexate or Imuran or Benlysta, I don't think we've answered that question. Would you say that's?
I think you're correct. We have a number of these immunosuppressive medications which are powerful, they're potent, and they're effective. Methotrexate, Imuran, you mentioned Benlysta, Cellcept. So we have several of these medicines, even sulfasalazine. So we have a number of these medicines. We tend to use them for a long time. Is it safe to use them for 15, 20, 25 years? We're not entirely certain, but we do know these medicines work. And we do know that in some cases, if we stop them abruptly, we can face flare-ups. We don't want to do that. So this is a discussion with your physician about whether you can taper or gradually reduce these medications after a long period of stability of the lupus. Good question.
I think we're at the point in scientific history where we're just starting to answer these kinds of questions. To study a medicine and get it approved by the FDA, the Food and Drug Administration, it takes a lot of money to run these kind of trials. Tudor is in the back talking or has some flyers on some of the lupus trials that we help with through the LUCIN network. But doing a trial to stop a medication does not make anybody money. And so often these are observational things that we notice that, like Dr. Ballou suggested, persons who are in a long, stable set of disease begin to question. Us as rheumatologists might begin to question, do we really need it? And so usually I think most rheumatologists would recommend, well, we wouldn't stop abruptly, but that we would wean slowly and see how things go.
Just one comment. This is something we grapple with in dermatology quite a bit, and it's nice to be in the situation where a skin condition is controlled. To be in a place where discoid lupus is well controlled, and it's very easy to start treatments. But because of the reasons Dr. Antonelli mentioned, one of the hardest decisions that we have is when to stop treatments. And there's not good answers, and hopefully they'll come in the future.
Very good. Some good advice and an answer as best as we can at this time. So we'll move on here. Can you tell us when we should go to the emergency room? Many ERs only view us as drug seekers. So what about going to an emergency room for flare-ups of lupus?
Question, and I think that unfortunately this label that one has unfortunately had made with an ER visit thinking someone is drug seeking is also an unfortunate reality as well. In general, lupus flares or it should, an evaluation in an ER setting, it can be an actually very important thing. Symptoms can include like severe pain, if you're having fevers and chills, concern for an infection, a new worsening type of skin rash could also be a good reason to go to the emergency room. And if you're concerned if the symptoms are sitting in sort of like a middle range, perhaps you have concern for a little bit of blood in your urine or a skin rash that has been going on for some time that is a little bit worsened than normal. And if you have a good sort of back and forth with your rheumatologist, that might be a good opportunity to message your nursing line for rheumatology to further have an assessment from them, whether or not they would recommend in the moment. But really having an assessment for especially symptoms of worsening pain that is difficult to do regular tasks, and if you have any concern for an infection, and the type of symptoms that one might be concerned for that kind of thing is a fever, as I mentioned, worsening shortness of breath, difficulty breathing, a cough, and chest pain are another example as well.
Yeah, I was just going to echo that, what Bisma said, as far as keeping in good contact with your rheumatologist. The emergency room has its appropriateness for those emergency situations, but I think it's unusual that a lupus flare may start abruptly. If symptoms start abruptly at 5 or 6 o'clock on a Friday, there's really very rare that we can get in contact with the physician. But here at Metro, we have the Metro nurse line. So calling and speaking with the nurse, there's protocols. I think if symptoms have been kind of smoldering for a while, sometimes I send my patients to get labs even without a visit, just to say, what's going on if I can't see them acutely. And a lot of times urgent care, so not emergency room, but urgent care can be sort of that in between to help assess.
one thing from a kidney perspective, like sometimes we'll send patients to the ER, particularly if we're seeing the kidney's ability to clean is, decreasing a lot quicker than we would expect from like lupus nephritis is not an uncommon thing. But if we have reason to think that this might be a particularly severe strain, like sometimes we look at biopsies and there are certain things we see that are associated with really rapid kidney decline. So to kind of expedite, so sometimes just based off lab work, again, that's not something that people don't really tend to have too much kidney symptoms unless things are already really severe. So that's one reason we may send, is if we suspect that kind of needing to expedite and figure out what's going on with the kidney quickly. But two things that can be concerning is like decreased to little urine output, but as well that can happen from a lot of these other things, not feeling good, dehydration, all those things. And if it's typically that bad to the point that you're just not urinating or urinating little, very little, that would be a good reason to seek out some more urgent or emergent care.
Excellent advice. So it is clear that use of the emergency room or urgent care center can be important for new or concerning symptoms, as mentioned. We'll move along. Here's a question that we all face and none of us like is, are there supplements, and I presume we mean over-the-counter agents, that can help with joint pain? And here I'll say joint pain, skin problems, kidney problems, or any other problems you have with lupus. What about going to your nutrition center and loading up on supplements?
So I love the generality and the elbow that you're giving us, Dr. Ballou. So we should point out, this is always my canned answer, that supplements are not FDA regulated. The FDA, the Food and Drug Administration, does very intense studies to see if a drug, a medication, Tylenol, Plaquenil, Benlysta, work. Supplements are considered a food, and so every supplement on the back of the bottle, you can find it. It says this supplement is not used to treat or cure any disease, even if it says on the front of the bottle that this is going to help X, Y, or Z. With that being said, I think this is a very commonly sought after sort of with patients with good intentions, right? We want to do things holistically. However, I think these are a lot of times the companies are they're interested in making money. The only supplement that I sort of with a grain of salt offer to my patients when patients have osteoarthritis, and so often older patients with lupus will have a component of osteoarthritis when the cartilage is worn down on the joints. There's some evidence for glucosamine chondroitin, in particular the DONA brand has some evidence. It doesn't cure the arthritis, but if it helps with pain after 6 to 8 weeks, I say it's probably worth the money. If it doesn't help the pain, then save your money and go and exercise, like I told you before.
Thank you very much.
One thing too I didn't mention earlier with regard, not supplements per se, but over the counters, is from our perspective, from the kidney, being mindful too of medications you might use for pain, like ibuprofen, naproxen, Aleve, that those things, and when you already have kidney disease from lupus, can really make things worse. Topical medications are okay as long as you're not, putting them all over your body. But even then, there's been one or two case reports about that. I don't know if, other things may have been going on too, but topical NSAIDs and things are okay. But just if you're taking over the counter or supplements, certainly make sure to let your doctors know.
I can talk a little bit about topical over-the-counters and supplements. Well, supplements in general, there's very little evidence for benefit in any form of cutaneous lupus. Just kind of a blanket statement, and I have read about this a fair amount. In terms of topical over-the-counter medications, there's also a lot of agents that are not going to be helpful and very few that will actually be helpful. I would say that hydrocortisone over the counter is not going to be strong enough to do anything for most skin conditions, unfortunately. It's also not going to help with itch. It's not strong enough. The reason it's not strong enough is because that's the only thing that has been approved for over-the-counter use, because it's very low risk. And that's what generally gets approved for over-the-counter use. And that's fine. And it has its uses, but most skin conditions will not respond to hydrocortisone over-the-counter. Sunscreen is about the only thing over-the-counter that I think is going to be useful for your cutaneous lupus. And like I said, that's also with some caveats. Sunscreen is not very practical and it's expensive. I think honestly what Dr. Abity said about sun protective clothing, in addition to behavioral changes, is much more practical for the average person.
Thank you. I hope we address that satisfactorily. It's an important issue and one that all of us confront. So I'm going to ask one more, I think, very important question, and then maybe we'll take a 5-minute break to stretch and such, and come back, and because there are many more excellent questions as well. So the next question, and I personally think this is important for all of us, is there any empirical research regarding the occurrence of depression and anxiety in African American lupus patients? And I think this is very important. I would generalize it to occurrence of depression and anxiety in all lupus patients, African American, Hispanic, Asian, Caucasian, etc. And see if, and hopefully my colleagues can answer this question because I cannot.
The answer is there is a huge association with, these mood disorders, depression, anxiety, stress. In lupus in general, lupus being a chronic, kind of almost an invisible disorder for many individuals that affects people in so many different ways. The disease itself has been associated with these types of changes, as well as sometimes medications that patients can be taking from lupus can, over time cause these types of symptoms associated with potential medication burden or impacts where patients have difficulty with their overall lifestyle. And it's hard because these are types of difficult conversations to have and to bring up because you're having so many physical symptoms as well. What I will say is that taking care of your mental health is just as important as taking care of your physical health, and introducing new concerns within your mental health sphere of concerns of perhaps depression, anxiety, and to your doctor is very important, because this is actually very common. It is not an uncommon thing, so that we can help with establishing resources and provide counselors as well as social groups. The Lupus Foundation is one example of a type of foundation which helps with putting other lupus patients with other patients to help with, finding others that are similar and are going through similar types of events, which might help with the disease and the types of the ways that it can affect us mentally as well. So I think that really being open to introducing and mentioning anytime you feel something is very important, so that we can take care of you from all aspects is very important.
Thank you. An important question, and I'm sure all of you have confronted this in friends or family or loved ones. So I think it's a good time now to take a little break. We can stand up, stretch, and let's try and get back. How about Suzanne, is 5 minutes okay? Okay. Thank you for these questions, and we'll hope to answer questions from the audience on the second half.
For a virtual audience, I'm going to keep talking to you so I don't lose you. Okay. Perhaps you know some of these things, perhaps you don't. But I would like to invite you, if we have new patients, that feel free to reach out to us. We have a class specifically for you called the New Patient Education class. It's every third Wednesday of the month from 6:30 to 8. We have our wonderful niece, Risa Pishan, who facilitates the class. I can't imagine embarking on a journey with lupus and not attending this class. Also, we have various programs available for you in surrounding communities. We have a host of different support groups, and you can access that information online. We are going to allow you to do some questions, so you can go ahead and start putting your questions in the note box on your laptop or computers, and hopefully we'll get to the majority of them. But at the end of the program, there's going to be a form that we're going to ask you to fill out virtually, so please make sure you do that. I'd like to invite you also to join the Walk to End Lupus Now that'll be held at the east end of the bank this coming Saturday. We'd love to see you in person. I don't want you to wander too far from your desktop. I don't want to lose you because we have some exciting questions. And I know that some of these questions, sitting in the audience myself, I'd like to build off of. So please continue to participate with us and stick around. I know that. Nothing I can do about it. Again, make sure you put your questions in the note box, and we'll be back in maybe 2 or 3 minutes, so don't go far. We're back with a lot of good things here.
So we're going to get settled and restarted. And before we go back to questions, I'm going to give the mic over to Dr. Nora Singer, who's our chairperson. She had a couple of important announcements, comments.
Hi, thank you to all the attendees and faculty for taking your time on a Saturday morning. I had one other thing to say about supplements because I get asked a lot. And so we know that a lot of patients take turmeric, drink green tea, and pomegranates. And so in the usual health doses, turmeric are fine. Green tea, if you're going to use it, boil the water, let it come down from boiling, and then steep it for 10 minutes to get maximum benefit. And pomegranates are probably better whole, the fruit, or freshly squeezed juice than the juice on the shelf because the antioxidants tend to wane with time. So I hope that might be helpful. I know that many of you use MyChart. MyChart is still free at Metro. We don't anticipate there being a charge, so that's also a good way. Sometimes we don't get them as promptly on weekends, but many of us will hear MyCharts even on weekends. But I would say if it's more than 3 sentences or an emergency, you probably need to call the page operator, and there's always a fellow on call for rheumatology. Some of the insurance plans do cover sunscreen, so there are times when you can't avoid being sun exposed, and for those times, sometimes we can do a prescription and it's less expensive. We do know, the other thing I wanted to talk about was COVID. There's been a lot of difference of opinion about booster vaccines. We recommend them, but in patients who won't take them, I tell them if they get COVID to call early because Paxlovid and the other medicine can be effective in really treating symptoms, and people who are on immune suppressives in general are at much higher risk for COVID, and it's just ramping up. I've started wearing masks when I go to medical appointments and in the supermarket again. And if there's no answer from the on-call person, first it goes to the fellow, then it goes to the attending on-call, and then it comes to me, and I always answer because otherwise it'll go to my chair. And we don't want that. So we are available for emergencies on weekends. And there are some research opportunities outside. We're also participating in a biorepository and registry that's going to be a national one. And the idea is that people with important research questions that have been judged by scientists and community, right? There's community, lupus community too on all of our grant reviews now. Those studies that'll judge, that are judged to be important will have access to data and samples without having names on them. So if we really want medicines and understanding of lupus that works in a diversity of people, we also need to try and participate. We've done really well for the post-COVID study here, and we'd love to do as well for the lupus study, both in terms of numbers of patients and in terms of diversity. If you're unfortunate to have your lupus flare, we do have clinical trials also that you saw outside. But really, I think what the lupus community needs is answers, and the only way we're going to get the answers is through participation. And since you guys are all here, I assume you're all on board with that idea this morning, and I'm probably preaching to the choir, but thank you for your time. Oh, I had one more question. At the end, Dr. Antonelli described shared medical appointments. We haven't done them yet in lupus, and there are some things that we'd need to organize to do that, but she'll describe what they are, and I'm interested in what their group feedback, if you think patients in general would be interested in them or not. Thank you very much.
Thanks, Dr. Singer. All right, so Dr. Ballou and I flipped, and so I'm going to moderate. And so the first question on our submission list will be for our rheumatologist. Are there any advances in treatment or management of AVN, avascular necrosis?
Yes, so, avascular necrosis, it refers to a type of disorder where a patient can lose blood supply to their bone, and that can cause some horrible type of pain as well as bone abnormalities. It can occur often in the hip, and it's often a complication at times for patients who've been on steroids for a very long period of time. In terms of advances within AVN or avascular necrosis from, we have really good diagnostic methods now with MRI for further assessing whether or not this is something that's going on. In terms of like treatment and management, usually we do focus a lot on pain and reducing steroid usage as much as possible to prevent these types of further diseases. And if it extends off to a further type of extent, I know involving orthopedic surgery could be potentially important, but mainly preventing this is a very important thing. And in terms of like further management, I'm not, super aware. I have read regarding stem cell therapies kind of in the works for in research for avascular necrosis, but I don't know if Dr. Ballou, you have anything to add.
Unfortunately, I do. Okay, thank you. Unfortunately, I do not. There is no new treatment on the horizon for AVN, which is a terrible problem. And as you mentioned, the key is prevention. And the best thing we can do to prevent it is to use the lowest possible dose of prednisone.
Great points. Our next question is for anyone. Is it common to have feelings of slipping away or an out-of-body experience due to depression and anxiety with lupus?
I would say yes. I think that, we referred to earlier the common aspect of how this is a chronic condition with medications, as well as just how involved within one's personal life having lupus can really affect one's mental health. And symptoms such as depression and anxiety can be common, but also symptoms of what, this describes some form of dissociating and feeling like you're not within your own body. And these are all different types of ways of addressing that one's mental health may not be at their best. And just again, to state, it's very important. This is one of the symptoms as well to mention and to go over with your care team, to talk about with the people that are closest to you, and further have a conversation so that we can help you in dealing with this.
Just one thing to add in regard to mental health, it is also important to be aware that sometimes out-of-body experiences, things like that, or especially if it's associated with racing thoughts or other symptoms of mania, can be a feature of bipolar disorder or the development of schizophrenia, both of which can occur in populations where systemic lupus is starting in the early 20s. So it's very important to be aware of that and talk to your doctors and make them all aware of all of your symptoms.
And at times can also be like a negative aspect of some of the medications, including steroids. So always, important to talk to your doctor and mention it.
Excellent points. Moving on to the next question. What are the best things to alleviate dry eye and eye pain due to Sjogren's? This person says the patient is already on civilamine, Restasis, ibuprofen, fish oil, and turmeric.
Sjogren's is a type of syndrome that can cause, and it can be associated with many different types of autoimmune conditions, but it causes symptoms of dryness of the eyes and mouth, among many other symptoms, but those are quite common. And it sounds like this patient is currently already taking Restasis, which is something that helps with the lubrication as well as symptoms of irritation within the eyes. I would advise, talking to your doctor regarding the addition of different types of anti-inflammatories and also involving ophthalmology in your eye care for different types of medications that may be added alongside these current very standard. This is a very good list of medications to be on for initial symptoms for dryness, but perhaps having an involvement with an eye doctor could also assist for further medications.
Correct. So Sjogren's syndrome, which occurs in maybe a third of patients with lupus, is dry eyes, dry mouth, dry skin, and it's due to an attack on the glands underneath our skin that produce moisture. We all have moisturizers in our skin 24/7, but if you attack these glands, as happens in some patients with lupus, then you get the dryness. It's very difficult to treat. You check with your eye doctor regarding eye drops. You check with your rheumatologist regarding dryness of the mouth, which this person did, and they're already using a number of medicines which are only partially effective. And in terms of dry skin, which is often a problem, we check with our skin colleague.
Sure, dry skin is a very common problem, and especially during the winter time for everybody. And there's a question later about hand moisturization, which there's going to be some overlap with this answer. But in general, you want to use a very thick product if you're going to moisturize, something with a base of petrolatum, which is essentially Vaseline, something that's greasy, so that when you put it on, it's going to stay in place and actually last a while, rather than a lotion, which generally you rub it in and it's essentially gone. It's not actually staying on your skin. The other thing you can do is you can use mineral oil, and other oils are fantastic moisturizers for skin and hair, if your hair can tolerate it. And using oils, not essential oils necessarily, but just mineral oil in particular, in the shower, after you shower, is very useful. You don't want to get a whole bunch on the floor and fall down, but it's very useful as a moisturizer. So those are some tips about moisturization of the skin.
The next question is directed to the dermatologist, but could also be for our rheumatologist. Can scalp pain without hair loss be related to lupus?
Yeah, I agree. This could be directed at all of us for sure. And I'll start with skin lupus. Can severe scalp pain without hair loss be related to skin lupus? Generally, no. It shouldn't, mainly because most of the time when cutaneous lupus occurs on the scalp, you will have some hair loss, except for perhaps very early in the condition. If you have very early discoid lupus, you could have some pain associated with it. That being said, it's generally not going to be severe, and it is not going to be in the absence of hair loss. But in terms of other reasons for scalp pain, there are many, and I think I'll pass it back to my colleagues to discuss rheumatologic thoughts.
I would add that in general, like pain in general, many sites is a common aspect of lupus, and I would suggest that perhaps, like for example, sun exposure and excessive type of photosensitivity to that region, because it's directly overhead, can definitely cause irritation and scalp pain, among other different types of aspects. Irritation at the skin level without signs of actual hair loss can occur as well, and that can cause worsening pain. Patients can have types of referred pain as well. So referred pain is essentially when you have pain at a different site, but it's kind of localizing to the areas around the scalp. So areas such as like neck pain, or if you have pain at the sinuses, it can radiate over to the scalp region as well. And that could be a reason for experiencing pain without having any form of like derm or skin issue or hair loss associated with it.
And one other aspect to also think about, I'm just trying to imagine like the inspiration behind this question is any symptom you have, if it's bothersome enough, I understand like where you can be worried about, is this lupus? But one thing we try to do as physicians is never to anchor ourselves into a single diagnosis. But if you have something that's bothering you and then you come to us to get evaluated, it could be a number of many other things. It's very possible to have lupus and then another skin condition or something else. There's lots of conditions that can look like lupus, can have the joint pains that you can have in lupus, or lab values that are similar to lupus that turn out not to be lupus at all. So, in a case with severe scalp pain, and that's a good reason to come get checked, no matter what it is. So just something to keep in mind, even though the lupus might be something that you're worried about, it could be anything, and so it warrants a good exam.
Great point, Dr. Abidi. I think in our medical training, we're all early taught Occam's razor, that many symptoms are often from a single condition, but as we practice, or as I practice, I learned Hickham's dictum that a person can have as many diseases as they want. So the next question, my primary care doctor isn't too informed about lupus. Should I use my rheumatologist as my primary care provider? Dr. Ballou?
That's a challenging question. So yeah, among general practitioners, there's variable knowledge regarding lupus, even because primary providers have to look at the whole patient, and they have a very complicated visit sometimes if they're managing a lot of different problems, diabetes and high blood pressure and stomach disorders, and consideration of lupus may not be high on their list. It's always worthwhile to discuss this issue with your rheumatologist. I think in general, rheumatologists do wish to see patients with lupus because we think we have, with current medications and new medications, we do think we have a number of therapies to offer that are effective. I always want the patient to check with their primary provider as well, so that their primary provider knows about new medications and so laboratory testing can be coordinated and is not done excessively frequently between the primary doctor and the rheumatology doctor. So it's a matter of communication. And I think we can usually do this successfully.
Well, another thing to take into consideration is, so from my standpoint, I'm concerned with skin lupus, and there's usually a small, really like small chance that it can then turn into what we call systemic lupus. But in those cases, those involve multiple organ systems, lungs, kidneys, the blood, brain. They can all be impacted by lupus. And so having a primary care physician that can coordinate between the different like specialties and also take care of other comorbidities, just like we were talking about, it might not be your only condition. I think there's a lot of benefit into having a diverse care team rather than pinning yourself into one specialty, because I think it's better in most cases to have multiple eyes on you. And I think anyone really, dealing with your human experience has a role in helping you get treatment. I mean, whether it's one doctor or the other, or your friend who just catches something that they think is abnormal, and they say you should go check out your doctor. Those people are kind of those that open the gates into getting treatment. So I think it's good to keep a diversified group around you.
I should just mention we're very fortunate here at Metro because where us rheumatologists see our patients with lupus and other medical conditions, our clinic is exactly right next door to our dermatology colleagues. And I can't tell you how often this is helpful. Thank you, gentlemen.
And from my side of things too, even in non-lupus patients, as people get kidney disease that's more advanced, they become more reliant on our care. And so I get this question a lot too. And I always think it's like we were talking about earlier, depression, anxiety, particularly in kidney patients, lupus patients, it's very overwhelming to have your life revolve around these conditions. So having a primary care that's also perhaps more experienced in, medications, behavioral therapies, other things that can help that, certainly I don't get to practice as much as I've become more focused on nephrology. I think that into even as things as like primary care, they have social workers, things that like they may be able to provide and may have better links to resources that kidney social workers and the people we use may not have. So I think from not only the doctor's expertise, but the resources they have access to, it makes sense to have more of a multidisciplinary approach as opposed to just one person.
All great points. Thank you. So Dr. Crow echoed a little bit of this question. The next question was, what suggestions do you have for maintaining moisture in the hands while on prednisone? And I'm going to also pair that with since we're going to focus on dermatology. Our first audience question today is, do you have to have a butterfly rash to have a diagnosis of lupus?
So in regard to moisture in the hands, I can't say that it's been a common occurrence that this has been mentioned as a side effect of prednisone to me. And I have a fair amount of people on prednisone for a variety of reasons. But if this is happening to you, I think a lot of the same strategies that I mentioned earlier are important. And the main one would be using moisturizers regularly on the hands, but also right now we're in the middle of another COVID surge, unfortunately, and everybody's washing their hands a lot again. And that's fine, and it's important. That being said, even though it's counterintuitive, hand sanitizer is actually less bothersome to the skin of the hands than soap is. Soap is extremely irritating everywhere. It's irritating when you shower, and it's certainly irritating on your hands too. So when you can, unless your hands are visibly soiled, replace hand washing with hand sanitizer. Your hands will thank you. And that could be why this person who asked the question is having problems maintaining moisture in the hands, is because of frequent hand washing at this point in time. In regard to the other question about, do you need to have the rash of acute lupus, the malar rash, to have systemic lupus? No, you don't. It's just one criterion in a group, and there are many patients who never have the malar rash, or perhaps they have it during treatment. It's a variable symptom, and I honestly don't see it all that often. I think I see other forms of cutaneous lupus much more often, especially discoid lupus. In the setting of systemic lupus, acute lupus, the malar rash should only occur in the setting of systemic lupus, however. So if you're seeing it, it's much more likely, if that's what it is, that the person actually has systemic lupus and it's not by itself.
So I'm going to rephrase the question then. Is there one criterion that all lupus patients, or virtually all lupus patients, have? A blood test?
One criterion?
The dermatologist wants to answer that one.
The anti-nuclear antibody should be positive in pretty much all lupus patients.
Correct. The ANA test is positive in, we currently think, 100% of lupus patients at some point. So it is a blood test, and your doctor will do it. In terms of symptoms, the most common symptoms are joint pains, and that's in about 90% of lupus patients, and skin problems in about 70 or 80%.
Our next question from the present audience: how does the age of onset of lupus affect the progression of the disease, or does it?
This traditional, like what we know, the age of onset for lupus is within like the second to third, or between the ages of 15 and 45 is usually when or the traditional woman of childbearing age is a timeline that we have patients have an onset of lupus. In terms of if that age range changes, kind of like the progression of the disease or worsening of the disease. From my understanding, if it's at an earlier diagnosis, there is a higher risk for furthering more organ involvement, more systemic involvement, and other types of diseases such as like kidney involvement within the disease, as opposed to if someone were to develop first signs of lupus and become diagnosed with lupus at a later age.
I agree, and I think our dermatology colleague will also, that the younger individuals, meaning adolescents, are more likely to have increased disease severity.
Certainly with nephrology, certainly with the kidney, that's the case.
And severity in terms of skin lupus, in particular discoid lupus, implies generally more widespread spots of discoid lupus. And if it occurs below the head and neck, that's generally a sign that it's a bit more likely that the patient is going to either have systemic lupus at the time or progress to it later.
Our next question touched on a subject we haven't addressed yet. So what about gastro issues with lupus? What is going on in our system in regard to lupus?
Within the GI system or the gastro system within the abdomen, patients can experience inflammation in all sorts of different ways. Patients can have symptoms from lupus that may range in the form of like inflammation from abdominal pain. They can have different series of infections, and general inflammation can affect pretty much at any site, really, in that way. I'm not sure if there are other types of disease associations you would like to add with that as well.
Yeah, yes, you're correct. Absolutely. The stomach can be involved, the intestines, the pancreas can be inflamed, the abdomen itself can be inflamed in lupus. And just as importantly, some of the medications we use can contribute to GI symptoms as well, such as many patients with lupus take anti-inflammatory agents. These need to be discussed with your doctor because they can irritate the stomach and further contribute to symptoms. So we have to pay attention to GI symptoms at virtually every visit with our lupus patients and do our best to try and control such symptoms. It may require seeing a gastroenterologist.
One more item, if you go right to the top of the gastrointestinal system and talk about the mouth, the oral cavity, the ulcers that occur in the mouth with as a criteria for systemic lupus, and also we see in a lot of our cutaneous lupus patients are something to pay attention to. They're usually multiple and recurrent over time, and they don't stay forever. They come and go. But that's one other area of the gastrointestinal system.
Our next question, we spoke before about supplements, but this question is, what role specifically do vitamins play in lupus? And in particular, vitamin D, B, niacin, magnesium, and ginger. If anyone wants to comment.
I was actually talking about this earlier with some of our fellows up here about the role of vitamins because I'd studied this and heard that vitamin D is often low in lots of patients that suffer from lupus. But on a lab test, what I was informed was that vitamin D can often go down in the setting of inflammation, which this condition is pretty much characterized by. So it may not be a lab value that's showing that you're low in vitamin D, but clinically you might not be low in vitamin D. I think the recommendation is before even starting a supplement, kind of like going back to what we talked about before starting anything, it would behoove you to have that conversation with your doctor and get some lab work done to truly see if you're deficient in one thing or the other. And again, like we discussed earlier, there may not be too much evidence supporting these things. Not to say that it would hurt you, but it's not a lot of evidence maybe to say if it would make a significant change in your disease course.
We can measure vitamin D levels and vitamin B12 levels. It's a very simple blood test. Your primary doctor may not do these tests, but they are generally worthwhile doing in patients with lupus. So you should inquire whether your vitamin B12 and your vitamin D levels are adequate. Very simple, easy blood test, and then you know the answer. We can supplement these medications quite easily. So it's something to pay attention to in the care of your lupus.
Excellent point. Our next question refers to Plaquenil or hydroxychloroquine. common standard treatment in lupus. Does Plaquenil help control inflammation?
Plaquenil is actually a very great medication to use in lupus, and I often see like most patients being on some degree of some dosage of Plaquenil. It does help with inflammation. I think one of the ways that we try to describe it is that it helps to almost like quiet down the degree of inflammation that one might have with lupus, and for that reason, it's a really great choice for the joint as well as the skin findings that one may have with lupus, and perhaps it might be like a baseline drug, and then perhaps patients may require more medications on top of Plaquenil depending upon if they have other symptoms from their lupus. And it is also considered to be a generally safe medication without many side effects. Occasionally can cause a little bit of tummy upset or GI upset that can be tailored with your doctor, in different ways depending on how you can take it. And at times, very rarely, it can cause some symptoms of visual symptoms that it's important to have an established visit with your eye doctor and a regular one to continue monitoring for Plaquenil.
All great comments. I just want to say one more thing. I love Plaquenil.
We have a vaccine question next. If a person gets the COVID vaccine, can he or she get Paxlovid?
I'm sorry, I missed the last point.
So if a person gets the COVID vaccine and then they contract COVID, can they take Paxlovid for the treatment?
They can. If you're going to use Paxlovid, it's best used at the very beginning of symptoms. It's most effective in individuals who begin with fever and cough, so fairly severe symptoms, in which case it's recommended to begin it within the first day or two of symptoms.
The next question is a little more specific. So this is a patient with myasthenia and lupus, myasthenia gravis and lupus. What can I do for hair breakage caused by the disease? The person cannot tolerate Imuran or Plaquenil.
So hair breakage, a lot of times goes back to hair care. And I think it's something that people sometimes ignore or pay less attention to when they're ill. And I think that the first thing that you should look at is your hair care routine and the parts of it that are beneficial versus not. So I would look there first. In terms of underlying medical conditions that can cause increases in hair breakage, a lot of it has to do with deficiencies. There is evidence that iron deficiency can result in hair breakage, and there can be increased hair breakage with some medications. I don't believe that myasthenia gravis or systemic lupus necessarily is directly linked to hair breakage. So I would assume that this patient may have something else, or perhaps a hair care routine which is not benefiting their hair strength and caliber.
Dr. Crow, you mentioned to kind of look at the hair care routine. So you had mentioned washing hands can be very irritating. So can you comment on hair washing sort of frequency and sort of what we think in the general population is okay, or maybe that's too much?
That's a great question, and something that I've read and talked about a fair amount. So I generally think that people wash their hair too much, but it also does depend somewhat on the type of hair that you have. So generally in Caucasian patients with lighter skin, they can tolerate washing their hair more frequently to the point where the hair doesn't break as much and doesn't fall out and it doesn't irritate the scalp. That being said, in African American patients, hair washing needs to occur less to maintain. Now there are some folks who can get away with that, but at the same time, once a week or every other week is generally what happens in African American patients. And that, when doctors ask about hair washing, and in particular dermatologists, and say, how often do you wash your hair, because we're going to use a shampoo for treatment, you can't assume everybody's going to be washing their hair with the same frequency. And you need to be aware of that, because increased washing will lead to increased hair fragility. So I think goes right along with that question.
Excellent. Thank you. And so our last written in question, and then we'll see if there's extra questions from the audience. Why are there frequent reassessments after being treated for years? You don't have lupus now. So I guess the question would be, how often is lupus reassessed? Does it change depending on the duration that a person has lupus?
It's an interesting question. Usually when a patient has been formally diagnosed with lupus, we're not hunting to reassess on a continuous basis. What we're doing, in fact, instead is reassessing through medications someone's progression of their inflammation, the maintenance of their medication, and we're surveying the some of the medications can be a little bit of a high risk for some labs. So we're surveying your labs and making sure that your general lab work is stable with those medications. We're assessing for the degree of lupus affecting your body, and we're asking you clinical questions, doing a full rounded exam. So we often don't, years into a diagnosis, repeat, for example, an ANA to establish a repeat assessment of lupus. I think perhaps in this type of situation, maybe a patient can unfortunately run into a situation, and I'm sure many have, of misdiagnoses, or perhaps someone is searching for an alternate diagnosis on top of the lupus, but generally we do not repeat assessment for the presence.
I would like to have my kidney colleague address this question, because lupus nephritis, kidney disease, is so important. I usually like to insist that the patient return for evaluation every 3 months, and I would like to have our kidney colleague address this.
Yeah, I certainly agree with that, because in patients, particularly who have one kind of lupus nephritis, like we talked about, where those complexes affect the kidney, there's 30% chance that it could start to affect a different kind, or a different area, or it can relapse. And monitoring of the urine, before was there blood and now we're seeing more protein, or there wasn't blood before and now we're seeing it, it can indicate that some of those different types or different classes of lupus nephritis might be there now that wasn't there before. So certainly in patients whose systemic manifestations have calmed down, or lupus nephritis has calmed down, monitoring every 3 to sometimes 6 months, depending how long the urine, to see what's changed, is important. And then 2, because from the kidney perspective, we still monitor even if there's no signs of any flare-ups, because we want to make sure we're tailoring our therapies, that those blood pressure medications, that Jardiance and the Farxiga, making sure we're lowering the protein in the urine that might chronically be there as much as possible, because people with lower protein in the urine tend to have slower progression of kidney disease, less cardiovascular risk, less chance of death, all those bad things that of course we're trying to avoid. So certainly frequent monitoring, even with resolution of systemic lupus or lupus nephritis, is certainly still important from the kidney standpoint.
Very good. And I would agree entirely with what you say with respect to kidney disease. And in terms of other lupus, even in patients who are doing well, I'm particularly interested in having a follow-up at least annually, to be certain that there is nothing else that is going on, and to check, sometimes to check a laboratory test to make sure that the patient has not developed kidney disease, which they won't have symptoms for, and to make sure that the medications they're taking are safe for them.
Yeah, I generally in dermatology follow the same dogma that a once a year exam for somebody with cutaneous lupus is a good idea. Most likely more often if they have active cutaneous lupus, in particular discoid lupus. And the reason for that also is that you can get skin cancer within areas of discoid lupus. And not a whole lot of people know that, and it usually only happens after a long period of time when you've had uncontrolled discoid lupus. But you could develop pretty aggressive squamous cell carcinoma within areas of discoid lupus. So that's just one more reason to see us regularly if you have discoid lupus.
I think the general point to get from everything everyone's saying is that it's a little different from like those acute illnesses you get a cold, you get a fever or something, and it just goes away. With inflammatory disorders like this, our goal is to reduce inflammation and reduce your exacerbations, but there's always this level that's kind of smoldering, and our goal is to keep it low. It might wax and wane and go a little higher. Sometimes you get joint aches, sometimes you aren't having joint aches. Then that's why we want to keep seeing someone, because if we treat you, we use a lot of medication, we treat you very intensively, and then everything goes away and then we just stop. Then instead of having this low level of control that we were trying to aim for, you might have just exacerbation and gone, exacerbation gone. So our goal is to see you and evaluate you periodically, so that way we can hopefully increase your quality of life and prevent you from getting as many as few exacerbations as possible.
Thank you. Those were all great points. I'm going to pass the mic to Adrian and see if there's any questions from the audience.
Okay, before we do that, I just want to say, to mirror what sort of that question started, is what we're seeing in the offices, particularly with biologics. So patients are getting on biologics and their lupus looks really good, right? And so they end up at maybe a new rheumatologist, they switched insurance for whatever reason they have to switch, and then that doctor is going, I think I'm going to take you off of that because you don't, I mean, we're hearing this a lot at the office. So just something to think about from that perspective. And I think probably where that question came from was what we're seeing and hearing a lot at the office is particularly patients on biologics having such a, maybe a level of remission going on there and somebody else saying, hey, you don't have lupus. So something to think about. You want to say something?
Yes, just briefly. We didn't touch on this very much, but you mentioned biologics, and we have at least 2 new biologics within the past few years. These medications are extremely powerful, and they're likely to be very effective. They represent a new avenue for treatment in lupus that we haven't had previously. So they're wonderful possibilities, very expensive, require close monitoring, but can, and we think in some cases, lead to even possibly the remission in lupus, which would be wonderful. But we are very careful in terms of tapering these medications if a patient is doing extremely well, which is what we do see.
Send some patients into a bit of a panic. Okay, anybody from the audience in person have questions today? Hallie?
First, thank you for all the great information that you have given us. So I appreciate it. I have a page of notes. My question is, if you have other autoimmune disorders and a variety of lupus symptoms, with the exception of the butterfly rash, and you have a negative ANA, could you still have lupus? And part 2, if you have not seen anybody because your primary care physician is not well versed in autoimmune overall, how do you start to find somebody new?
In regards to the first question, I think you mentioned someone experiencing symptoms of multiple discoid lesions. Multiple symptoms with a negative ANA.
Multiple symptoms with a negative ANA and also other diagnosed autoimmune disorders.
Right. So when we diagnose lupus, we don't necessarily have the best what we call diagnostic criteria. There's no set list of 5 things that we need to see in order to make a formal, complete diagnosis, but we do use a very well-rounded, exam as well as laboratory evidence, and we discussed the ANA being positive, and I mean, it's listed at 98 to 99% of patients, but pretty much 100% of patients require that diagnosis as part of the diagnosis. But we tend to see a lot of patients who do have a lot of different autoimmune conditions, and we treat them based upon the type of symptom the patient is having. And so our different type of anti-inflammatory medications may help kind of see progression of the disease, but patient may not be formally diagnosed with lupus while they are in this type of disease subset. So it's not necessary for it to be verbalized as lupus.
Correct. As we've discussed briefly before, it's possible to have Sjogren's syndrome, an autoimmune condition, with a negative ANA. So it is possible, although uncommon, to have an autoimmune disease with a negative ANA. And Sjogren's is a good example.
I'd like to take that second question about looking for a primary care provider. I think in medicine today, there's a high demand for primary care physicians. There's high physician burnout. And so when you're looking, you want to look for a couple of things. You want to look for someone who is close to you. You don't want to be driving an hour to look for a primary to be able to see your primary care physician or primary care provider. And I think it would be ideal if you have nowhere to start to ask your rheumatologist, hey, who might you recommend? Sometimes I see patients where they have a large burden of lupus, but they might not have a lot of other primary care concerns, but it's still important to have one. And so I often say, well, I work well with these couple of physicians or nurse practitioners, and they might be willing to accept you because I know I have a really good working relationship with them. So some thoughts.
Anyone else? Dr. Singer?
I think the other opportunity for physicians who are open to it is for patients to help train them. And we do have, I think that Suzanne has materials within Lupus Foundation, and we certainly can talk about topics and say you tackle one topic a session with your primary care physician. You can also help bring them up to speed, presuming they're interested.
Thank you.
Hi. Can, when one of your children have lupus, is it given by one of the parents? Is this hereditary? Is this, because my daughter has SLE and I've been diagnosed with lupus with blood clots.
A good question. Lupus, from what we know, does have a very high genetic association or hereditary association. And one of the common questions we do ask in our clinics is if someone in the family member, especially a first-degree relative, has had lupus, symptoms of lupus. It usually is a high proportion of patients who do have that. And then a lesser proportion of patients, we have seen some environmental associations with the development of lupus, but more often than not, there is some genetic association. But even so, there is a possibility to have lupus without anyone in your family having lupus at all. And usually we have like a lot of tests and kind of further assess perhaps patients were never diagnosed, or it is a common, it's possible. And that's because of the way our genes work. It's very different, and the way they kind of produce the actual development or the what we call the phenotype of a disease is different than what's inside.
Anybody else? Susie.
I'll just add one thing to that real quickly. Those are all really good points, and yeah, there is a strong, like, family history does take it, like, you should take that into account, but I don't want you to think like, oh, I gave this to my daughter. It's not something you can give her. It's just something she was more prone to develop because of the genetics and the way everything works, like Dr. Bashar was saying. it's definitely not something that's like infectious you can give to other people. It's just sometimes it's just kind of the draw of the hand, and there's more risk when you yourself have it. So that's something that's important to internalize, because like we were talking about our mental health. I don't want anyone to go home with anxiety saying, oh, I gave it to my daughter or son, and things like that.
Yeah, I'm curious as to mixed connective tissue or undifferentiated. I know all the people in the room right here, and I know that many of my lupus community has multiple autoimmune problems. Okay, what is going on? Help.
Blue's laughing, so we know it's a complex question. The way I like to explain it to patients is these are academic questions that don't really matter. In medical school, we are taught about here's the cookie cutter for lupus. Here's the cookie cutter for mixed connective tissue disease. There's a cookie cutter for undifferentiated connective tissue disease where a person doesn't really fit into any of the cookie cutters, but there's a lot of overlap. Truth be told, it's very much like a Venn diagram where if you've ever seen those like circles that are overlapping, these are academic questions for the physician to think, should I use this lupus algorithm or should I use this mixed connective tissue disease algorithm? And I think it's really important to keep an open mind that patients are not textbooks. Patients may fall into one cookie cutter at some point, but to always keep an open mind so we're not missing anything.
Okay, any other questions from our audience here? Okay, I'm going to ask one question, and then I do know there's about 4 that have come in online. I think in the interest of time, because we're almost at noon, we will forward those to you and get those answered and send them to our at-home audience. This one is in particular to anti-chromatin antibodies, and I'm looking at you. So over time, a patient with anti-chromatin antibodies, the interest from physicians goes up and down and up and down and up and down. It seems to be in one of those up phases as a biomarker for lupus nephritis. What are your thoughts on that?
Yeah, I think ultimately when it comes to lupus nephritis, what we rely on is the biopsy. I mean, the anti-chromatin, it can point more towards where like I was talking about, the location of, it can maybe give us a stronger indication of what kind or what we might see on the biopsy. But there are a lot of those other things as well, like the blood and the protein and new blood pressure, swelling, all those other things we look at too. So it's a piece of something that might give us some indication, but really we look at everything as a whole. And even, there are times, where I'm expecting to see one thing on the biopsy and see something else. So even with all those clinical contexts, sometimes it's not always, doesn't give you the clear answer as to what the biopsy and what things are going to quite look like.
Makes sense. Thank you. I believe Suzanne's going up here. Okay.
Okay, this time this concludes our program, but wow, I could go another 2 hours with you guys, probably all day actually. And I know you're all bashful out there, but you asked me all the questions and you have the opportunity to ask them. So if you have more questions and you're just bashful, put it on a card, send it over. We'll get them taken care of for you. In your folders, everybody has these. Do the docs have these as all? So I'm going to throw a wrench in things because I know Adrian has a different idea than I have. But if you turn these in, I have a drawing today, and you're all eligible for the drawing. And we're going to do that at lunchtime real quick. So I need these. No one's leaving the room without one. Our funders really enjoy having data. And on behalf of the Lupus Foundation, Aurinia Pharmaceuticals, Metro, your generous offer to use your facilities today, and your physicians, and the Ohio Department of Health, along with the Commission of Minority Health, we say thank you. And always, the Lupus Foundation is here to guide you through your journey. No one should be on this journey alone. There is no I in the word lupus, but there is us. Okay, I have some staff in the room. Adrian, who's my left arm, Alex, who's my right arm. We couldn't do without our nurse in the back, Rita Pishkal. I messed that up, I'm sure. And we have a new audio guy that joined us from New York. He's new to the chapter, so we welcome Chris. And our minority outreach coordinator in the corner is Letha, and we have some navigators in the room. And to our guests, thank you very much. And you'll have a blessed day, and I welcome you to lunch in the other room.